And essentially, I'd like to start with throwing out a big shout out and thank you to CMDA. So, yay! So they are sponsoring the session and making sure that we get all the paperwork, I's dotted, T's crossed, all that good stuff. And our last session is one that's a little bit of a bummer in that we're going to look back at some of our lost opportunities and the fact that we, throughout the history of medicine, have spent most of our time talking about people from one area of the world, basically one racial background, even though various countries are involved, and essentially one gender, and mainly because it was a deliberate exclusion of many centuries of various groups of people. And we're going to throw some of those roadblocks into relief so we can see what they were, how they've been overcome, how they're still being overcome, and how certain people whose names we deserve to know more about got through those, and we should have some good biography starter lessons for how to actually appreciate the contributions of people who would otherwise have been completely invisible to us any time earlier in history. So we're going to start by going way back to ancient times and hit the few women in ancient medicine that we actually know something about. So mythologically, we talked a bit about how we had Hygeia and Panacea. They were the two mythical daughters of Asclepius who oversaw the idea of preventative medicine, Hygeia, and keeping things clean, not letting disease develop in the first place, and Panacea, the cure for all worldly ailments. Now, these two were not directly based on Isis, but the Egyptian goddess Isis did have some healing aspects to her character. Many of the female gods had all women priesthoods, and those women priesthoods would actually take care of things like childbirth, midwifery, women's health, and they did serve some purposes like that, although not every female deity had their temples working on that same principle. Now, the temples of Asclepius did not have a gender breakdown, but in general Greek society, women and men were relatively strictly segregated, but we don't know a whole lot about where women would have gone for any of that temple-based healing. Now, we move a little bit, not necessarily forward, but a little bit sideways to about 2500 BC, and we have the first named woman in all of history. Now, that's Merta. She's going to be a healer, an actual chief of the physicians for the pharaoh at that time. So not only a woman healer, but one who was actually very high status and very highly ranked in the court of the pharaoh at that time. There's remnants of a papyrus that she's reputed to have authored or at least given training for her students from, talking about various diseases affecting female patients and anatomy, surgical procedures related to childbirth. And she was roughly contemporary with Imhotep, who was one of the first medical practitioners in ancient Egypt as a man that we're aware of. Now, it is fun to also know, Merta is actually the first named woman in recorded history. So the first person whose name we actually know who happens to be female. The funny story to that is the first named male we know is some guy who received a bushel of grain in an ancient papyrus from Assyria. So not somebody who did anything particularly grand, but we know his name, but I don't. So, but we could find it out if we needed to. So another person who is worth noting is Agnya. I always butcher these names, Greek names. Agnodice. And she was a woman physician in ancient Greece. And Greece was a relatively sexually segregated society. Women were kept indoors a lot of the time, and men lived in the public sphere, women lived in the domestic sphere. She actually disguised herself as a man to train and practice medicine. And she was actually denounced by another doctor, largely for poaching off of his poaching off of some of his clientele. He was probably unhappy that they were getting treatment from her, possibly more effective. And so he denounced her, and she was sentenced to be killed. But in a nice little echo of some of the great plays of the time, the women and the wives and the daughters of many of the famous politicians in ancient Greece and Athens at that time actually went on strike and refused to allow that sentence to be carried through. So she was well thought of enough by her patrons that she was actually spared from death because of the efficacy of her treatments. So in the classical era, we've already mentioned that the extreme domestication in terms of their entire sphere of influence was one thing that kept women from practicing medicine. There were temples and ostensibly temple priestesses who were devoted to women's health and maintaining some practice related to obstetrics, gynecology, what we would call them today, but they were largely kept very much out of any sort of literate or intellectual enterprise by the men of the time. As different monotheistic religions, Judaism, Islam, and Christianity moved into Europe and the Middle East, not only were all gods wiped out, there weren't going to be any female deities, let alone temples associated with them. There was only going to be the temples or the churches devoted to the single monotheistic god of those religions. So at that point, the temples were wiped out, and obviously the temple priests and priestesses lost their livelihoods along with any of the health-related activities that they would carry out. So midwives remained present, and midwives have been present throughout history, but you're going to see they've had a relatively rocky history throughout time. Midwives have usually operated, I wouldn't say in a suspect manner, but always off to the side of official physicians, official surgeons, very much a craft art practiced by women and specialized, but usually operating by not making too much noise and incurring the wrath of the more established and more powerful male physicians who moved into obstetrics only in kind of the later, kind of the early modern period. So we got a couple bright spots. We had Guy de Chalac talking about a bright spot in medieval surgery, and we have one bright spot in terms of women practitioners of medicine. And that's going to be our friend here, Hildegard of Bingen. She was a nun, and she was actually going to be, she wrote a lot on religious topics, but also medical topics. She had a few different books, Causae et Curae, Physica, and talked about various diseases, classifying them, but particularly paying attention to women's health and diseases and issues affecting women. She believed very strongly that imbalance of the humors, or disequilibrium in general, could actually bring about diseases and leave you open to contagion. Now, we've already talked about how humoral imbalance brought about disease, some sort of loose contagion could bring about disease, but she very strongly felt that it was the imbalance that left you vulnerable to contagion. And if you were balanced, those things that you might be exposed to might not actually affect you. So we all know that's wrong now, but I also still take my zinc and vitamin C whenever people around me are sick. So you might just kind of take a note to think that these ideas are not nonsensical, even if they're not based around our current theory of disease. Most of the people at the time were working around a very comprehensive theory of disease and tried to mend their treatments accordingly for their different patient populations. She talked a lot about how mental states affect people's ability to heal from disease and to recuperate, as well as various women's issues. And if you take a good look at this painting of Hildegard, I was really struck by, she just looks a lot like Maggie Smith. So maybe Maggie Smith could portray her someday. That'd be nice. Professor Mcgonagall, for anyone who doesn't know her actual name. Okay. What do you guys think? Do you know her from Harry Potter mostly, or Downton Abbey, or Harry Potter mostly? Okay. She was in a great comedy about this doting old mother who returned to her family, but she was also a serial killer, but she only killed really unpleasant people. It was a riot, so check that out. All right, so in the Middle Ages, there's no real ability for women to work in any sort of a temple setting, any sort of a monastic or intellectual setting like a university. So women healers tended to be very marginalized. They tended to be older women who would be lay healers, herbalists, midwives, and they, again, were not front and center in terms of medical treatment, but people knew how to find them when they needed them. Now, being relatively like a craft art, the actual efficacy of these treatments would really vary a lot from person to person. And especially if you have an herbalist, even if this herbalist who prepares simples, things are made from one herb, they might know a lot about what they're doing, but does that mean that all herbs that they're gathering are created equal? You're going to have different concentrations of different active ingredients at sometimes, not at others. And there's very little understanding about how active ingredients in those various herbs might actually work to help people. So foxglove might help people with dropsy or heart failure, or if you overdid it, it might kill them. It's very difficult to know that And so even though these people had some know-how, it was still very touch and go. And that left them exposed. When negative outcomes came around, or sometimes even worse, these women would develop, would get quite a bit of property, money, or power in the local area. They would often be denounced as witches. And so that would be a very common thing to have happen to these women, is that someone has an axe to grind because of a treatment gone bad, or they feel that these people are gaining too much authority in the local area. A lot of the women who were burned as witches throughout history were actually lay healers, midwives, and so forth. So one of the interesting examples of this is that in 1322, we have Jacoba Felice was charged by the faculty at the University of Paris for practicing medicine. And basically they were just upset that she was doing what a doctor would do, visiting the sick, examining the urine, feeling the pulse, touching the bodies and limbs and neck. And one thing I think you'll notice from here is that she's not doing anything bad. She's just poaching on the territory that the physicians had staked out for themselves. And that's going to be a consistent theme. As women healers get displaced, it's because it's felt that they're encroaching on their male colleagues' kind of area. And then later, in the early modern era, actually really the contemporary era, the AMA and other medical associations will actually expand their scope of practice and push midwives out of practice as OB/GYN, officially an MD or DO specialty at that point, took over that craft knowledge and training. So even though midwives and doulas are still around, their prominence is nowhere what it once was because of the expansion of the physicians and surgeons into that space. So essentially, by the 14th century, there were no women officially practicing medicine of any kind anywhere in Europe or the Middle East. Were they there? Yeah, but we can't tell you who they are. They may have been illiterate. They may not have had their names recorded, even if they did know how to read and write. So those healers who operated in the background have largely been lost to history, although always historians are trying to find new sources to be able to dig down and see if we can get any information about these people. All right. Oh, another interesting example of this is my phone going off. Let's fix that. Is that Queen Elizabeth, this is in the 1500s, so late Renaissance era, getting close to the Enlightenment times, was actually petitioned to intercede on behalf of a woman healer who'd been arrested. And this is going to be Margaret Kennicks, and she was basically distributing herbal remedies, basically little simples or single ingredient herbal remedies. And one of her chief secretaries, Frances Walsingham, was basically trying to put her case forward for the Queen to intercede. The College of Physicians had basically said, yeah, she's just trying to make a living, her family's very poor, and she's the only one who can support them, but we still don't want her to be able to practice because it sets a poor example and a poor precedent that might make it seem as though women can actually act as doctors. At the time, that was felt to be an entirely sensible line of argumentation. That even though it was for she knew what she was doing and she was actually able to do it and support her family in that way, the mere thought that a woman would be working in that was enough for them to actually shut her down. And sadly, Queen Elizabeth did not intercede on her behalf, going with the College of Surgeons and Physicians on that regard. All right, so one thing you might have noticed is that throughout this entire time, we've got a variety of medical healers. We have midwives, we have physicians, we've got surgeons, we've got apothecaries, people who make the different drugs and compound them. And so they're all doing their own thing. Now, it's not as common anymore, but who's ever heard of a doctor being called a quack? Anybody ever heard that term? A few of you? It used to be a pretty derogatory term for a doctor. A bad doctor was a quack. What's interesting is that actually comes from this era, from the 1700s, but a quack was not a bad doctor. It was any medical professional who did something outside the scope of their normal practice. So if you were a midwife, childbirth, you were good to go. You could do that and people would not be too upset. If you were an apothecary, you could mix drugs, or at the time, mix up various herbal remedies. If you're a bone setter or a surgeon, you could do those things. But if you were a surgeon and you gave someone some pills, you gave them some sort of an herbal compound, you are poaching on the kind of livelihood of the apothecaries, and that was a quack. So initially a quack was someone who didn't stay within their lane as a medical professional. Now, at this time, we had a variety of people doing a variety of work, but they all basically agreed on the same principles, is that illness was a result of humoral imbalance, and that we would have contagion that might result, you might have bad air or miasmas that would result, but the main thing that caused people's health to vary was the humoral imbalance. So everyone had the same underlying theory, even if they practiced in slightly different ways. So that era, as I mentioned already, the humoral theory of disease from Hippocrates up until the 1700s held sway for about 1,300 years. So we've already covered that. It's pretty appalling, and I think in the survey results, a lot of people mentioned that in the first talk, that they couldn't believe that Galenic anatomy, Galenic theories of the humors held sway for so long. But here's the big one. Dun, dun, dun. Humoral theory is not the longest-lived medical error. The longest-lived medical error is this massive bucket diagnosis that was thrown at people for millennia and is absolutely useless. And that diagnosis is hysteria. So hysteria is a condition with large red font, bold-faced quotation marks around the word condition that was thought in ancient Greece to result from women's uterus detaching at the time of menopause and roaming their body, deranging the humors and causing all kinds of horrible problems. So hysteria was thought to be a derangement of women's ability to think and act properly, and quite honestly, it was just simply women acting in inconvenient ways, and it was thought to be a medical problem that had to be interceded with. Now, this belief in a uterine source for hysteria persisted long after the fact. People realized, yeah, the uterus is always kind of right there. It doesn't really roam the body. But the idea that the uterus was the seat of it persisted for a while. So medical knowledge, anatomical knowledge got better, and yet we found a way to justify the diagnosis of hysteria despite that. In the Middle Ages, on into the Renaissance, into the Enlightenment, any possible rationale for prescribing someone as having hysteria and treating them accordingly, often depriving them of their property rights, their ability to run their own life, was put forward. Abstinence, too much sex, too much thinking about sex, all of these things were thought to cause hysteria. Basically, anything you did could be held against you as a diagnosis for hysteria. In the 1800s, it was considered to be a neurologic disorder. You could treat it with mesmerism or eventually psychotherapy. And eventually, people realized that hysteria is just a bucket diagnosis. It's garbage. It's something we throw at a problem when we don't know what it is, and sometimes it's a solution in search of a problem. It doesn't actually correspond to anything. So eventually, thankfully, hysteria was removed from the DSM-3 in 1980. I was 7 years old. I was alive when that happened. So there we go. So hysteria, these days, when you think of something being hysterical, what do you think of? Yeah, you're laughing, maybe a little nervous laughter. It's kind of boisterous laughter. So you're slightly out of control. But historically, it did not mean something was funny. It meant that you were kind of deranged and out of control. And that was a diagnosis largely applied almost universally to women throughout history. Just quick note, there were men who had been diagnosed with hysteria as well, although ostensibly not because their uterus had detached, one would hope. So, hysteria really was just a means to an end, and that end was to make sure that women were not given the opportunity to engage publicly to the same degree that men were. And so essentially, any possible way to diminish women's capacity has been something that's put forward. So as theories of disease, theories of illness and treatment have changed over time, you'll still find that those new scientific understandings are co-opted to justify the exclusion of women. It's really interesting how sexism and racism will really grab on to new trends and try to hold on strongly that way. So in the 17th century, we have humoral balance, we have humoral theory. It was felt that women's brains were just too cold for strenuous thoughts. Now, it's just cold outside in general today, but anybody feel a little phlegmatic today? Yeah, right here. So, in olden times, that'd be said, well, yeah, but since you're a woman, it's extra cold, and you really shouldn't be thinking heavy thoughts at this time. So we move forward. We have pathophysiology in the 1800s. Well, guess what? Well, we know better than humoral theory now, and now we know that women's skulls are just too small. They just don't have the raw computing power to handle this stuff. Now, I hope it's clear that I think this is all garbage as I present this, but these are the justifications that were put forward during the time. Any justification to this ad hoc, predetermined decision was done. And in the 19th century, we had a physiologic justification. We now were thinking about biochemistry and physiology, and it was thought that if you were thinking too hard as a woman, you might strain your ovaries. Now, I define you to strain your ovaries through any activity. It's just hard to turn those ligaments one way or the other. But essentially, these justifications have been put forward every time there's been an advance, and you just got to watch for that. And just out of curiosity, we live in an age of molecular biology and genetics. Has anybody heard any particularly intriguing genetic rationales for why women are not able to engage intellectually at the same rate that men are? Has anybody heard anything? There is an element of Q&A here, sorry. What do you think?
I know I've heard that genetically women are predisposed to getting PTSD, developing.
Okay, so women genetically predisposed to PTSD. So when stuff like that, the thing that's damning about this though is genetic things and variation does occur from male to female. So you have to ask, where's the data? Was the data controlled? What kind of a study are we talking about? Or is it something that's just looking for justifying this foregone conclusion? Any others? Yeah.
I believe I've heard not too recently that women are more right side brain dominant, which is the arts and the music and the domestic life.
Yeah.
And where men are left brain dominant, where we have to do the math and the science and the physics and the hard labor.
Okay, there you go. So when we have neurologic separation of function, then, oh yeah, well the right brain has all that artsy-fartsy stuff. That must be, women are prone to that. And the left side is more intellectual and, regimented. That's obviously male. So again, you take something that's real, localization of function, but you whip that reading onto it, and it's suddenly being used in a way that really won't stand the test of time. All right, so just watch for those things as time goes by. Cultures always try to find ways to justify the status quo, and, sometimes that's innocent, other times it's really detrimental in the long haul. So essentially, pardon me, women physicians and women surgeons weren't a thing, even in the 19th century, even after women would be allowed to attend medical school. Some places actually allowed women to attend medical school, but hospitals wouldn't allow them to practice. It was very difficult for them to actually start an active practice, even if they could attend a university eventually. Universities were closed to women for a while, but even after they were open, it was certainly not a level playing field by any way. Women who obtained a university degree were sometimes able to practice with their husbands, but rarely were able to get their own practice together. Medical internships, different what we would now call residencies, were not open to them. And so they often had to go various other places to find any kind of training. Now, once again, it's time to give a little bit of a shout out to our DO forebears. AT still opened the first school back in 1892, and women were allowed to matriculate on an equal basis as men. Johns Hopkins, same basic idea, but 1 year later. So whenever Johns Hopkins gets all the props for that, just think with a small little note of pride, AT still beat them by 1 year. And Harvard and Yale, not until after World War II. Women were not allowed to actually attend Harvard or Yale medical schools until after World War II. So, always good to keep an eye on that. So let's choose some names, modern era women who actually were able to break through a lot of this, basically this roadblock that was set up in their way. So we have the two Elizabeths. First up, Elizabeth Blackwell, an American, was going to the Geneva Medical School in New York, and she founded an infirmary specifically to treat women. This is something that actually would happen with her and the next Elizabeth, Garrett, on the next page. they weren't able to get into hospitals that excluded women, so they were able to find the means to get a hospital or an infirmary started specifically to treat women. So that was one way they were able to actually practice. Organized nurses and got ready for them to handle patients coming back from the Civil War, and opened the Women's Medical College with her sister, Emily. And they had actually fairly high standards. For these colleges or these hospitals to survive, they actually had to have decent outcomes because people were gunning for them. So you actually had to have fairly high standards, hold yourself to a fairly rigorous academic curriculum just to be able to continue. Now we have Elizabeth Garrett. In the UK, she was the first woman doctor, but she actually had to go to France in order to study. She wasn't allowed to study medicine in the UK, had to go to France in order to do so. And we're going to see that theme crop up on a few more slides as we proceed. So, same basic idea. She had to found her own dispensary specifically for women just to have any kind of a foothold in the medical establishment there, and established the London School of Medicine, so quite a bit of parallel between her and Elizabeth Blackwell in the US. Now, this is a name you've probably heard, but you may not be aware that Maria Montessori was actually one of the early women doctors. She was actually an early physician, and she obtained her medical degree in Italy, in the University of Rome. Actually, it's said in modern Italy, because Rome was a city back then, but Italy was not actually a country, or had just barely become a country around that time. The Risorgimento was in process at that point. So she was working at the medical school's psychiatric clinic and developed an interest in childhood development. And when you hear the word Montessori, what do you guys think of these days? Montessori schools. So she worked in childhood development and put her degree to work in that venue. But it's worth noting Maria Montessori was actually a physician prior to founding those schools. Now, Maud Abbott, I've mentioned very briefly once already. She was Canadian. She's studied at McGill University and actually was unable to attend medical school in Canada or the US, but came to Europe and Switzerland, got her medical degree there before returning. And she, I don't believe, was actually able to practice medicine extensively, but she did become faculty or at least instructor at a university and was able to start collecting malformed hearts. And she had a large collection of cardiac malformations, and that was her special study, and was able to publish an atlas of malformed hearts, the Atlas of Congenital Cardiac Diseases. Now, this expertise came in very helpful for someone we have talked a lot about before, Helen Towson. Helen Towson studied with Maud Abbott and basically figured out what sort of heart malformations were present, used her fluoroscope to actually diagnose those malformations in her patients, figure out which ones were present, how extensive they were, and come up with some sort of a treatment plan. And eventually, as we mentioned, she was able to come up with, in conjunction with Vivien Thomas and Alfred Blalock, the first procedure to repair a heart defect. Now we should note, it was not a heart operation in the sense that the heart itself was not cut into. It was the large vessels creating an artificial ductus arteriosus that was done. But it was the first procedure that was used to treat a heart malformation. Now, she did all of this work in the late 40s, early 50s, published the congenital malformations of the heart, and went through multiple printings. Basically, every pediatric cardiologist on Earth can trace their lineage right back to her because she basically inaugurated that field. And she eventually got to be full professor at Johns Hopkins, but it took an additional 20 years after she was instrumental in the first heart operation. So even though things were somewhat open, opportunities were not still equal by any means. I think if I came up with a new operation, they wouldn't really hesitate to make me a full professor, and she still had to wait 20 extra years on top of that. So towards the end of her life, she did one other thing that's been very prominent. Francis Kelly, the head of the USDA, and Helen Towson were instrumental in blocking the marketing of thalidomide in the United States. Now, who's heard of thalidomide? Now, thalidomide is a very effective anti-nausea medication, but it also is an incredibly potent teratogen, meaning it causes birth defects. And the main thing it does is it causes limb defects. And the really terrible thing is that the majority of morning sickness, the extremity of morning sickness and that nausea occurs about the same time that the limbs are being formed. So taking this drug is almost guaranteed to cause limb malformations. And children with this are born with called phocomelia, where they have basically no humerus or forearm. They just basically have their hands sticking out from their body like flippers, or an absence of the limbs altogether in some instances. So this was seen in Europe where thalidomide was being used, and she and Frances Kelly were able to very effectively lobby to stop it from being marketed in the United States, which is why we don't have thalidomide babies in the United States that frequently. Now, thalidomide is available. It is an excellent anti-nausea medication in some circumstances, but it is 100% absolutely contraindicated in any woman who might even possibly be pregnant. So just FYI, that's the story on that one. Whoops. All right, so going to jump back now to osteopathy. We mentioned that we've got Helen Towson as a great success story from women being admitted to Hopkins. Women, a year earlier, as mentioned, were admitted to the Kirksville School by A.T. Still, and we have 4 women in the first graduating class. So they are Nettie Bowles, Lou Kern, Mamie Harder, and Blanche Still. They are all 4 in this picture, and it took me forever to find a picture that was not ridiculously blurry showing the first class. So they are there. The AMA, obviously the large MD political organization, did not accept women until 1915 or so, whereas the AOA had women available to join right away. So hooray, good job. In 1908, only 35% of the DOs in the country were women, but by 1923, rough equity had been achieved. That's going to vary a bit, but rough equity had been achieved at a relatively early state. That's going to vary as time goes by and World War II, the Korean War, other wars come in, pulling males but not females out of the country to serve. And here's the thing, even though we want to pat ourselves on the back, we shouldn't get too carried away. It was, women were able to be DOs and join the AOA from a very early time, but it wasn't until 80 or more years later that we had the first woman president of the AOA. So just be aware, let's not get carried away with how enlightened and wonderful we all are, because that's usually when the rug gets pulled out from under your feet. So let's talk a few names. Nettie Bowles was involved with osteopathy throughout her whole life. She was someone who knew A.T. Still and the family. She was the first publisher and editor of the Journal of Osteopathy, current JAOA, and became the first vice president of the AOA, and she was put up to be the first woman to be nominated in 1917. But as we noted, 1917 first nominee, 2009 first president. Yeah, that's a pretty big span. So once again, take it with a grain of salt. But essentially, the DO degree was a way for women to be more involved at a higher level than the MD was at that time. Louisa Burns is another big name of women in osteopathy. She was involved in a lot of research on viscerosomatic, somatosomatic, somatovisceral reflexes and what those pathways and those spinal interactions might be. So she was looking at how disease could manifest in one part of the body and actually refer to other places and set up those dysfunctional tissues and those great words that you guys have to deal with now, like boggy. What's another one? Ropey. Give me some other ones. Boggy, ropey. Rubbery. I like rubbery, okay. Rubbery throat disease. Let's keep that one as a diagnosis. So yeah, she was involved in a lot of the basic research going into that. She was the dean of the A.T. Still Research Institute and was that for 20 years, and essentially set up a lot of the research that makes osteopathy unique. Now sadly, after the Flexner report, DO schools were locked out of funding for federal research dollars. So when we talk about osteopathic research and how it doesn't seem to be at quite the same level as MD research, it's really because there's this huge funding pit that DO schools have been climbing out of for more than half a century. And so that's hopefully getting better, but it's still not great because a lot of the work that DOs do is done through experience and practice, but doesn't always have very strong scientific underpinnings. Now, I'm not trying to talk some smack about any of the techniques. However, when you try to dig down for the scientific basis for them, sometimes it's not well justified, even though the techniques might work really well. So anyone who wants to take that research initiative and try to find out ways to account for inter-rater reliability errors, subjective measurements, and ways to make that more firmly based on a scientific statistical analysis would really do a huge service to the profession. So just throwing that out there. All right, so one of the last things to finish up with is overall women, matriculants, graduates in medical schools. Now you'll notice the dashed line along the bottom, those are women graduates from medical school, all medical schools, male graduates in the green line, and you'll notice they start veering really close to each other. In about 2007, 2008 was the high water mark for equity between male and female graduates from medical schools. Now, since since medical degree programs have gained a little bit more in the numbers, that has separated a bit further. But if we get to the point of true equity, sooner or later we'll just have male and female graduates just kind of swapping places as we move from 51 to 49 and so forth. Although technically, I think women make up 50.1% of the population, so there should be a slight majority in there if it's perfectly representative. All right, so we're going to switch gears real briefly and see how the same basic trends have affected African American and Black physicians throughout time as well. And the same basic justifications have been used. Now, think back, if you remember, when we talked about phrenology and things like physiognomy, examining physical traits, you'll notice that a lot of the basis of that was essentially in racist and ethnocentric ideas about which people were superior. For those of you listening at home, big air quotes right now, which people were quote unquote superior, and it was again a foregone conclusion. People took European traits and decided that was the high water mark and denigrated everybody based on that. And if you're denigrated as being less able to work intellectually than someone else, you're not going to have the same opportunities to attend medical school, research, get a graduate degree, and so forth. So this is something that has affected minorities in the same way it's affected women, but with a slightly different flavor. So in 1900, around the time the Flexner Report was taking shape, we had 10 medical schools in the United States that were actually dedicated to taking Black African American students. But when the Flexner Report came out in 1910, it shut down a lot of American medical schools, and it was particularly hard on traditionally Black medical schools. So by 1923, we only had 2, Meharry and Howard University. Now, as time progressed and we moved into a little bit further along, schools began to desegregate, and African American students had more opportunities to attend any of the medical schools that were present. But as we'd expect, those opportunities were far from level. And it wasn't helping that when people who would like to attend medical school tried, they were told, you know, medicine's really not a great career for African Americans. You should probably just concentrate on public health or some affiliated health field. Same sort of advice that were given to women who were interested at the same time. So fairly dismissive and really acting as a roadblock. So desegregation came in fits and starts, probably not anything to be too proud of. And by the time we enter, roughly modern times, we had 2 more medical schools that were founded to particularly attract and graduate African American doctors. We have Morehouse and Charles Drew University. So despite this, we do have African American and Black physicians who were able to practice in the United States, but they had to do what you'd expect the women physicians had to do. They had to go out of the country first to come back to have any hope of getting their expertise in the first place, and then find ways to practice. And first name we have is James Mccune Smith. So he went to Scotland. He actually went to Glasgow in 1837, quite a long ways back. This is going to be almost 30 years prior to the outbreak of the Civil War, so very early in American history. And he started practicing in Manhattan, and he was actually a good friend with Frederick Douglass, and contributed a lot to the writings and the conversation that Frederick Douglass had in the abolitionist movement, and trying to make sure that people understood that slavery was not something that should be countenanced and should actually be gotten rid of, so that people could all contribute as equally as possible. So he was very well known as a doctor, an essayist, an abolitionist, and actually was involved in organizing the Underground Railroad, all while practicing as a physician and working with his own pharmacy in Manhattan. He was obviously excluded from the AMA and other local medical societies, and it was strictly because of race. Back then, you could just say, you can't join us because you're a different race, and that was good enough of a justification for those groups at the time to stand by. So another thing that's really kind of a sad afternote to this is the racism was so pervasive that his descendants really lost track of the fact that they were related to the first African-American doctor. And it was because they had started intermarrying with some white neighbors, and they didn't want their black heritage to be something people knew about. And so that was more a source of shame than their amazing ancestors' career was a source of pride. So just a very strange afternote to priorities brought about that way. So now let's bring up the person who basically brings all of our groups together for tonight. We have Rebecca Lee Crumple, the first African-American female physician. And she is just spot on amazing. So if you think about what she did in her life, you're going to feel like, okay, I don't feel useless, but I don't feel anywhere near as brave as I thought I was. Essentially, she got her medical degree from the New England Female Medical College in 1864. So at this point, there is actually a college that will accept her, even if practice opportunities aren't that great. And she working in public health, but also medical treatment for black communities throughout the North. And after the Civil War, after Reconstruction had started, she went to Virginia to help treat the recently freed slaves. Now you can just imagine the racism any black physician is going to experience going to the recent South right after the Civil War. How would you like to be a black female physician doing all those same things at the same time? So not only are you fighting the entrenched attitudes, you're fighting your own colleagues who don't like you simply because of your color or your sex. So she was going against all of that and still worked really hard to get some good works done in that area for the people who really needed the medical treatment at the time. So she eventually returned back to Boston, wrote a book on the discourses of health and how that could actually be something that would help women see medicine as a viable career option, and particularly African American women see that as a career option. Next up, real quick, so we already mentioned, what was the first heart operation? Vivien Thomas, Alfred Blalock, Helen Towson? Yeah, that's the famous story. That's the famous story of the heart operation. But it was not the first thoracic operation. First thoracic operation that we know of was carried out by Daniel Hale Williams, black physician, and he was the son of a barber and eventually attended Chicago Medical College, which is now part of Northwestern, and he graduated in 1883. So he went to and founded a hospital in Chicago, again, because practice opportunities were strictly limited to white physicians at other hospitals, and so he had to get his own hospital together to treat the people in his community, and it was a black-owned yet non-segregated hospital in the Chicago area. So in 1893, long before the 1940s, when we have the Blalock-Taussig Vivien Thomas procedure on the subclavian arteries, pulmonary arteries, a man arrived who had been stabbed in the chest, and he was actually bleeding into his pericardium. Now, thoracic operations were considered to be particularly hopeless. You couldn't crack the thorax, you couldn't do anything in there. But this man was dying very clearly, and so Dale was able to actually wait for this guy to go into shock and then operate. He was able to drain some of the fluid from the pericardium and actually sutured it together. Now, those of you who know the anatomy of the chest, know the pericardium, That's not going to seem like a big deal right now. It's right there, it's tough, it's fibrous, but at the time this was unheard of. And the patient survived and actually walked out of the clinic a little while later. Interestingly, it's the first documented thoracic procedure that was ever done. Someone else actually had done a very similar procedure around the same time, but hadn't published it until well after. So just be aware, Daniel Hale Williams did the first thoracic operation of any kind. Okay. Oh, and then taught at the Meharry Medical College. And real quick, when women and black physicians were unable to attend or round at hospitals, what did they have to do? They had to found their own. Same goes for the AMA. Black physicians were excluded from the AMA, so what do? You found your own medical society, and he was co-founder of the National Medical Association. And I don't know if that's still around. I believe it actually still is, but the AMA has, long since come around to allow both women and minority members. All right, now we've talked about Vivien Thomas already. Vivien Thomas wanted to go to medical school, but his savings were wiped out when one of his banks failed. Back in those days, if your bank went out of business, guess what? All the money of yours that they had was gone. That was it. So when the bank crashed, he had to go to work, eventually becoming a janitor in Kentucky, and he met Alfred Blaylock at Vanderbilt, and the two of them then went to Johns Hopkins and became a really just unparalleled medical research and surgical team. And Vivien Thomas, being black, not having a graduate degree, was not able to have all the same opportunities or the same financial resources that Blaylock had. And Blaylock, to his credit, he really fought for Vivien Thomas to be able to contribute, but Blaylock was not fighting for racial equality, for the good of the nation. He just wanted to make sure that his excellent lab technician was not obstructed in moving these life-saving things forward. So eventually, they were involved in the life-saving operation for the first operation on tetralogy of Fallot, saving Eileen Saxon when she was 11 months old. Now, I mentioned that operation already. Now, the sad news is Eileen Saxon didn't live a whole lot longer than that. She lived to about the age of 3 years, but that's 2 years longer than she would have lived otherwise with this first of its kind operation. And so this procedure was done with Vivien Thomas basically vulturing over the shoulder of the head of surgery at Johns Hopkins, instructing him on how to perform the procedure, how to tie the sutures, how to bring the arteries together, because Vivien Thomas had done this experimental procedure many times. Blaylock had done it once. And so that procedure, the fact that it worked, was a real boon to not only heart operations, but also the idea that you don't have to be a certain color to have medical surgical expertise, which at the time was kind of a revelation to some people. And so eventually the track record of success became immense. So 685 of the children who underwent this operation after Eileen Saxon survived more than 2 months, and 441 of those 685 survived past 15 years. And it's not that they died after 15 years, but by that time you had heart-lung bypass machines. You could actually go in and repair the defect directly. And so most of these people survived much longer than that because better options became available. So let's take a look at the numbers. The most recent set of numbers is actually a little bit old. It's from 2014, and we can see that when we look at the breakdown of medical school applicants, matriculants, and graduates, they tend to follow a pretty common theme. So we have a very low number of American Indian and Alaskan Native applicants, graduates and matriculants. Likewise, Native Hawaiian or other Pacific Islanders are not making up a large proportion of the medical population in the United States. Now, when we get to Black or African American students, matriculants, and graduates, again, 7%, 6%, 5.8%. Now, not a huge number, keep in mind. It's also, you have to look at what the average population overall is. And again, the goal is that the number of people in medical school should very much mirror the number of people in the population in general. And if we're not there yet, it's something to work on. And likewise, we have Hispanic or Latino students, matriculants, graduates, just a little bit under the same number that we have for African American students. Now, here's an interesting thing, is when we look at the physician workforce, Black or African American physicians, 4.2%, Hispanic or Latino, 4.6%. We look back at the number of graduates and matriculants, the numbers are higher. So hopefully that's a trend that we're going to continue to see. So even though we can't correct these inequalities by pushing a button, with gradual change and hopefully more enlightened outreach, more enlightened admissions procedures, the people who are talented enough to do the work will find that they have the opportunities to do the work regardless of their sex, their gender, their ethnic background, their race, and so forth. All right, and once again, first-year enrollment of female and underrepresented minority students, we're getting a little bit better. First-year enrollment of underrepresented minorities, not quite up to 10%. Female, first-year enrollment, just under 50%. So just because things are getting better doesn't mean the work is done, but we can at least feel that we're not doing anything horrifically wrong, as hopefully these percentages start to mirror the real populations of the country itself. All right, so that brings us to the end. Deep breath. And if it's too cold in here for you to take a deep breath, just let the icicles gather on your nose and shake a little bit. So a couple parting thoughts. The end of this talk, I really want to drive home the idea that good and profound contributions to medicine can come from a lot of different places. And when you deliberately exclude entire groups of people for what we're going to just say are completely unnecessary reasons, you're losing a vast sea of possible contributions. And I hope you've seen that the millennia that we've studied of medical innovation and change could sorely use a lot of progressive thinkers who are ready to push those things forward. A lot of stasis has taken place over this course, where a lot of things that were massively obvious errors in hindsight held sway for hundreds and hundreds of years. So just be aware that examining what's out there is vitally important, but it's also important to examine what we thought was out there and to always keep an open mind towards different hypotheses and different explanations that are able to explain the data. If it's backed up by the data that we're studying, we should contemplate it, even if it runs counter to our current understanding or the current paradigm of how medicine's practiced. Interestingly, there have been several examples of discoveries that were ahead of their time. So Hippocrates was on the island of Kos. He came up with the basic foundations of modern Western medicine based around the humoral theory of disease. But interestingly, nearby on another island were another group of physicians. And their theory on disease was that you had different afflictions affecting the organs of the body, and those organic disturbances manifested as various types of disease. Something way closer to our current understanding of what disease actually is than the humoral imbalance theory. The problem that we had in this case is that Hippocrates came up with a way for physicians to treat people based around his theory. These physicians did not. They had a theory, but they weren't able to put it into practice in a way that helped people actually see that their results were worthwhile. They weren't able to make the results convincing enough for their theory to stand against Hippocrates' wrong, but more persuasive theory. Chinese and Arabic medical scholars had described the circulation of the blood long before William Harvey, but those ideas were not distributed widely enough, or were forgotten, or in some instances possibly ignored in preference for that narrative. So William Harvey did a lot of amazing stuff. He was able to describe the circulation of the blood and how the changes that occur transitioning from fetal to adult circulation take place. But if he'd not had to discover the fact that blood circulates in the first place independently, if that knowledge had been preserved, he might have been able to go even further. A Chinese physician in the 1st century is reputed to have used anesthesia. So when did we get anesthesia? Anybody remember roughly when? 1860s, 1840s, 1860s. 1st century. Could have had a millennia of people not having their legs sawed off in horrible, horrible pain. So just be aware, it's always good to have extensive background in various areas and actually pull your expertise from a variety of places. One thing you'll notice about the people who are real luminaries in the history of medicine is that they often took ideas from one aspect of life and applied it to medicine. Renee Highfield-Laennec came up with the stethoscope by remembering a game that they played as a child and put it to work in medicine. So taking various areas, using that breadth of human experience and applying it to what you know might be the key to make a big step forward. And decades before, Ignaz Semmelweis instituted hand washing at the Allgemeines Krankenhaus in Vienna and stopped temporarily the spread of infection during pelvic exams. There had been people who'd theorized that that was true before. So British physicians, Alexander Gordon, Charles White, suspected that. Bafflingly, the American physician, Oliver Wendell Holmes, who had a newspaper column that people read every single day, didn't publicize the fact that he thought this was a way infection was spread. Just imagine the number of women who died, not in childbirth, but shortly after childbirth due to the infection that was brought about by this problem. And so you basically have a lot of missed opportunities that people could have jumped on if their minds had been open to reevaluating what they knew based on evidence. So what makes the difference? And essentially, it's being open-minded enough to entertain a theory. Now, if you are incredibly open-minded, you may get fooled by theory. Franz Anton Mesmer hit on some excellent concepts for therapeutic treatment of psychiatric diseases, but by insisting that his theory was correct to the exclusion of the data, he lost the ability to really make that contribution lasting and only had to be picked up later. So also, how do you communicate your findings? How do you communicate your position? It matters how you tell people things. Louis Pasteur is a household name and considered to be one of the greatest scientists of all time, not just because he was brilliant, although let's not discount that by any means, but because he was an excellent speaker. He really pounded his ideas home. In some cases, he did a little more harm than good. He actually browbeat people out of, let me give an example. There were people who thought that there might be disease resulting from the intercellular fluids that were present around cells. But Virchow and before him Pasteur were convinced that it had to be cellular in origin. And Virchow in particular hounded people until they accepted that it was cells and only cells. And they missed the opportunity for the fact that it's not just cells that can be the source of disease. That effectiveness in communication served them very well to get their points out, but they also need to be aware that sometimes there are more complicated explanations than just one or the other. So effective communication definitely matters. Ignaz Semmelweis did not communicate well. He didn't interact well with his superiors at the hospital. He didn't interact well with his colleagues, but thankfully, hand washing was eventually reinstituted, but could have been something that happened much earlier had he been able to convey that. So being right is not enough. Or as this quote put it, that I particularly like, great ideas and great inventions do not necessarily win acceptance because of their inherent value. If you have a good idea and you put it out there and you just wait for everyone to appreciate how brilliant you are, you're going to be waiting a long time. You have to keep pushing it. You have to keep putting it in people's faces. And it's going to get tiring. It's going to get irritating. And you're going to feel unappreciated. And you're also going to feel like, well, maybe I am the jerk here. Maybe I'm wrong. But when you have a good idea, you don't want to be crass. You don't want to be rude. I'd say Joseph Lister is probably the person you want to emulate in that you put your idea forward. You're forceful with it. You make your case, but you're also persistent. You keep putting it forward, and when you find the audience that's able to accept it and work with it, you jump on that opportunity, really drive it home, and hopefully make this world just a tiny bit better. All right, that is it. Good job. That's as close to an inspirational speech as I will ever be able to muster, so I hope you enjoyed that. Real quick, so at this point, anyone who's been around for all 6 sessions, make sure you've signed in, and again, today, make absolutely sure you've got the sign-in sheet. thoughtfully being waved in the air for your perusal right there. And so if you've been at all 6 sessions, we will get you a certificate of having completed it, and thank you very much for that. If you or someone you know missed a session, you're able to view the video either from this year if it's available, or I can send you the link to last year's session. You can do a short 1 to 2 page paper on that topic or on some topic of interest in it and get credit as well. Last thing, anyone who wants to become what I am inaugurating as a distinguished scholar of the history of medicine, send me an idea for a short paper that you would like to explore, and over the next year, we can get a 5 to 6 page paper together on some topic of interest to you, and hopefully some topic of ignorance to me. It's one way I get to learn a lot more about things is by getting a little perspective on some topic that you might find interesting, but I've not heard of yet. And so if that's something you find intriguing, send me some of your ideas. The process involves a lot of back and forth, so it'll be a lot of editorializing, and I know you're busy, so don't commit to it if you don't feel like you're interested in it, and I don't judge you if it's something you'd rather not worry about, but that is something we'll be happy to do and get that to you and go back and forth with that. 5 to 6 pages doesn't seem like a whole lot, but then when you get, yeah, some of you are laughing. Everybody just do this for a moment. That's pretty much what it's like. Oh, come on, play along. There we go. That's about what it takes. All right, thank you guys very much. It's been a pleasure.